episode of our weekly Sunday webinars. Over the past 4 months, we've taken advantage of the COVID pandemic. For the first 3 months, we had weekly webinars where we spoke about critical care endocrinology. Last month, we focused on transgender endocrinology. And this month onwards, for the next 2 months, we'll be speaking about gender specific endocrinology. To chair this session, we have with us one of our most respected teachers, someone whom I admire very strongly. And this is Professor S.K. Singh. Sir is past president of the Endocrine Society of India. He is also professor and head of the endocrinology department at BHU Banaras. A warm welcome, Dr. S.K. Singh, sir. And the floor is yours.
Thank you, Dr. Sanjay, and for your kind words. And thanks to Endocrine Society for organizing this kind of activity. When we are locked down, we don't have access to too much of academic activity, but this is a very good endeavor. I must appreciate this. And today we will be having this gender-specific diabetes challenges, and this will be and then we'll have a discussion and lecture by Dr. Jabbar. To chair this session, along with me, Dr. Manuel from Spain, Catalonia, who will be also co-chairing this session. And Dr. Manuel Pu is head of endocrinology service at German Trias Puzol University Hospital and director of German Trial and Puzol Research Institute. Leads the endocrine diseases research group at German Trial. Is a professor of endocrinology at the Faculty of Medicine of Autonomous University of Barcelona in Can Rui campus teaching unit. From 2014-17, Dr. Pu Domingo was the president of his Spanish Society of Endocrinology and Nutrition. 2017 to present is president of the Spanish Society of Endocrinology and Nutrition Foundation. Currently, also is the officer of European Society of Endocrinology at European Medicines Agency, and he had been he has been awarded by Carlos III Health Institute and European Project, has published 2021 scientific papers that speaks of his prolific temperament of writing scientific contributions to literature. Dr. Manuel Puig will be co-chairing with me in this activity. I hand it over to Dr. Sinath for the quiz and initiation and the questions, which would be followed by Dr. Jabbar through his lecture. So over to Dr. Sinath for the quiz and introduction.
Srinath, thank you for joining us. I'd also like to mention that today we will be doing the beta launch of the newly revamped website of the Endocrine Society of India, and we request you all to join us for that immediately after the webinar is over. We are also mindful of the fact that we are speaking about gender-specific endocrinology, and today in our panel we are all from the same gender. But I would request you to understand that endocrinology is a chronic disease. It is not acute medicine. So if you look at things in perspective, if you look at all the webinars, all the educational activities that the Endocrine Society of India does or its members do, you will find that there is a fair representation of all countries, all continents, thanks to Dr. Manuel, and all genders as well. So thank you. And with this, Dr. Srinath, please carry on.
Thank you, sir. At the outset, I would like to thank ESI for giving me an opportunity to be the quiz master for this session. So in total, there will be 12 questions, and the answers you can share in the chat box. So most of the questions will be in the true and false mode. So I think we can go with the quiz. So the first question, type 2 DM is more frequently diagnosed at lower age and body mass index in men. Is it true or false? Second question, visceral adipose tissue to subcutaneous adipose tissue ratio independently predicts higher cardiometabolic risk in females. Is it true or false? Third question. Menopause is associated with shift from gynoid to android visceral adiposity. Is it true or false? Fourth question. Higher impact of brown adipose tissue contributes to higher diabetes risk in women. Is it true or false? Fifth question. New biomarkers shown to be related to type 2 DM onset in women are all except option A is hepatokine futin A, option B is copeptin, option C is proneurotensin, and option D is gamma glutamyl transferase. Sixth question. Among the liver enzymes, the strongest association with incident type 2 DM is seen for option A is ALT, option B is AST, and option C is GGT. Question 7. Testosterone replacement therapy can improve insulin sensitivity and hyperglycemia in hypogonadal diabetic males. Is it true or false? Question 8. Men more often develop impaired glucose tolerance and women more often show impaired fasting glucose. Is the statement true or false? Question 9. Pregnant women carrying a male fetus have higher risk for developing GDM. Is this true or false? Question number 10. Women appear more vulnerable to stress-related weight gain. Is this true or false? Question 11. There is a positive association between BMI and heart failure risk among men, but a J-shaped association among women with type 2 DM. Is it true or false? And the last question. Diabetic men carrying angiotensin converting enzyme D allele have a higher risk for the development of diabetic nephropathy. Is it true or false? So total there are 12 questions and you can share the answers in chat box. So I will be sharing the answers after the presentation.
Okay, thank you, Dr. Shanath. As he has already asked the questions, and I'm sure that participants would be giving the answer in the chat box, we'll disclose the answer at the end and we'll discuss. But meantime, let us update our knowledge in gender differences in diabetes, and that would be dealt with by Dr. P.K. Jabbar. P.K. Jabbar is a professor of endocrinology in Thiruvananthapuram Medical College. He is also director and CEO of Insulin Institute of Diabetes in Trivandrum. Over to Professor P.K. Jabbar.
Am I audible, sir?
Yes.
Yeah. Yes, sir. Yes, sir.
We can make it a little louder if you have
I
the microphone. Okay. Yeah, fine.
I can.
Yeah.
Good evening. Good evening, Singh sir. Respected Singh sir, a senior teacher and past president of Endocrine Society of India, and my close friend. You really helped me for a lot for starting the endocrinology course in Trivandrum Medical College. I still remember with gratitude. Dr. Manuel, my friend Dr. Srinath, president of ESI, Dr. Sanjay Kalra, and my colleagues in Endocrine Society and ladies and gentlemen. Extremely thankful to ESI for giving a platform to discuss this topic in the webinar. My topic is very funny. It's a gender difference in diabetes. Apparently, it's a very unique topic and very rare topic, very strange topic. So whatever available literature I'll be discussing, and all the experts, including Dr. Singh and Dr. Manuel, will contribute a lot for clarifying our doubts also. My flow of presentation is like this. Slide is not changing. Hello, Renu?
Oh, you are controlling the screen, or the host is controlling?
Yes, coming.
Yes, coming.
My flow of presentation is very simple. I'll be discussing the statistical data, the risk factors, and I'll conclude with the very simple slide. That's my plan of action for today. If you look into the IDF atlas, every 7 seconds, one patient is dying from diabetes. Now, unfortunately, most of the death, around 50% of the death, is occurring before 60 years of fruitful age. Diabetes is more or less equally distributed in all age groups, except those who are achieving menopausal age, around 60 or 70, not truly menopausal age, there the women surpassing the incidence of diabetes. Fortunately, India, we did a study, INTAB study, that's an ICMR funded study, which showed similar frequency of diabetes in both sexes. If you see the data, again, so world across the data, on the left side, what you are seeing here is you have a lot of female patients here. On the South and Central Asia, Middle East also, you have a lot of women with diabetes mellitus. In the right side of the slide, men is mainly, of course, wherever you go, you can see diabetes males, 100%. But more incidence or prevalence is documented from Asia Pacific and Western region. Now, coming to the early phase of diabetes mellitus, that is pre-diabetes mellitus, you have the data like this. It's a broken line and continuous line. So, continuous line for diabetes, if you can see here, after the age of 65, females are overtaking here, whereas IGT, that's broken line on the lower panel, what you are seeing is that diabetes is very, very rampant, or IGT is very rampant in ladies. So it's not the IFG. IGT is very, very common in females. These are the documents available in the literature. Coming to the obesity, will define like this: BMI. The open slide that's on the left side, you can see here, that's for females. The dark one for males. So what is shown here, the BMI is more in females or women. If you split up the data again, BMI more than 25, more than 30, there also you have all the variables. Women are winning and ladies are having a lot of obesity and subsequent issues, which is documented already in very many studies. If you see the MRI picture here, it's a beautifully narrated here. Upper panel for non-diabetic patients. The lower panel, the C, that's for males, and females, that's the right side of the slide, which showed subcutaneous fat is good in females, whereas in the left side, what is shown here, you have very high levels of visceral and hepatic fat accumulation. Eventually, what will be the result? The result is the insulin resistance is tremendous. Now, how gender influence diabetes? Let us look into the risk factors. Risk factors you can divide into 3. The biological risk factors, psychosocial risk factors, and health behavior related risk factors have been documented. If you see the left side of the chart, that is biological, which includes your body mass index, body fat distribution. Dr. Srinath was discussing gynoid and antroid. Brown adipose tissue, which has got little protection, Certain adipokines also involving and influencing the diabetic risk. Of course, gestation diabetes mellitus, everybody knows that. Socioeconomic status, psychosocial, psychological stress, sleep deprivation, that must be the cause for increasing prevalence of diabetes mellitus in our techie group. They are having a lot of work stress also. On the right side of the slide, what is shown there, lifestyle diseases, smoking. See, if you are consuming a lot of sweetened beverages, that itself can produce vascular damage and increasing prevalence of diabetes mellitus. Alcohol, if the see your allowance is 1 pack or 2 pack, see if you are consuming more than 6 times of the allowance, you are a risk candidate for developing insulin resistance and subsequent diabetes. If you see the split up again, BMI, in both sexes you have influence and better prediction for type 2 diabetes mellitus in males, waist circumference more in females, and that's a very good predictor for type 2 diabetes mellitus in ladies. Metabolic syndrome, if you can read all these, high prevalence of metabolic syndrome, adipose tissue, hypertension is documented in females, and what is shown in the lower panel, no exercise at all, which has got a very negative impact on obesity and close association with increased adiposity in women. You don't have time, or you are giving some excuse also for that. Eventually, you are developing metabolic syndrome or diabetes. Now, coming to the split up again, IFT. IFT, you can see here, IFT is more common in males. On the left side, you can see males, you have a lot of cases of IFT, and IGT is more common in females. High testosterone, there is an association between high testosterone, 60% higher incidence of diabetes. Low levels of sex hormone binding globulin, that's a association in women, and very strong diabetic risk for females. Needless to discuss, GDM, sevenfold increase in diabetes incidence, and PCOH around fourfold risk factor for developing diabetes mellitus. Job strain also is a well documented one. Now, coming to certain small issues, low education, high occupation, probably negative impact in females, low socioeconomic status, strong association with the women, and very interestingly, low childhood socioeconomic status, which has got a fourfold high risk for developing diabetes mellitus, just like Barker hypothesis. Smoking, I don't want to discuss in detail. Everybody knows that is a very independent, very important risk factor for cardiovascular events. What is shown here is a bird's eye view of physiological and pathological differences in the sex. I can't read entire slide. What is shown here is there are a lot of changes in the males and females. If you are interested, you can see the reference quoted here. Now, coming to the third point, that is pathophysiology. Pathophysiology is both common in males and females. There should be a genetic predisposition. Epigenetic factors are operating, and you have insulin sensitivity changes, dysfunction of incretin system, and hypothalamic pituitary axis involvement, endocrine disruptors, bisphenol, which is very closely associated with obesity, probably metabolic syndrome is also associated with that. So what I want to tell you, that's a very complex pathophysiological changes both in males and females. Now, coming to the most important part, this is an important slide I want to discuss again and again. Now, everybody knows that type 2 diabetes mellitus is associated with the higher levels of vascular disease. In females, there's a protection from estrogen or sex hormones. If you are developing type 2 diabetes mellitus, if a lady develops type 2 diabetes mellitus, that diabetes negates a female advantage. Sex difference definitely exists in basic physiology, basic pathophysiology, preventive strategy, diagnostic process. Everywhere, this sex difference is showing its own impact. This paper published 10 years back in Menopause International What the author did was the causes of death in ladies and males. So what is shown here, females, they're having high incidence of coronary disease. On the right side, the chart shows 1980, the death rate, it was showing, okay, males was showing good number, and female also, it was showing good number. On the contrary, in 2000, the mortality in males is coming down, but females are not really coming down. And the author Graham Jackson, he gives the important message that we should concentrate on females to reduce the risk factor for preventing cardiovascular issue. That's a message he wanted to convey. This data published in Circulation Journal. On the right side, what is shown here, you have lot of risk factors in males, but on the left side, very pathetic situation. After 2000, the mortality rate is coming down, but females' death rate or mortality still higher than male mortality. So it's a very important statement from Circulation Journal. This is from Italian data, RIACE Italian multicentric study. What it showed, the results are very interesting. CVD risk factors are more prevalent. But when you look into the risk factors for vascular disease like glycosylated hemoglobin, LDL level, HDL level, non-HDL cholesterol, everywhere females data is very, very bad metabolic profile. So he also wanted to convey the message that in women with the type 2 diabetes mellitus, in this cohort, more adverse CV risk profile, and we should address these pathophysiological or risk factors for reducing cardiovascular mortality. That's an Italian paper. Another paper, this is from France. This is published in Canadian Journal. If you can concentrate on the left side of the chart, the upper panel is diabetes control. Second panel is BP control. It is okay. There is no significant difference in male and female. But when you come to the LDL level, there's a divergence. You can see the divergence. You can see, and females are having very bad LDL cholesterol. Eventually, they will develop coronary artery disease. So, what's the message? The Abdullah et al. In Canadian Journal of Diabetes Mellitus, he feels that females' risk factors should be addressed properly for reducing the vascular disease. This is a paper from France. This is on Social Medicine Journal. What the conclusion of author is, male diabetics are good. They're effectively managing their diabetes. They're having less depression, less anxiety. They're having very positive thinking also. Eventually, male's health status is okay than female health status. That is a message. Now, coming to the other studies available in the literature, all-cause mortality, you can read all-cause mortality, females are doing badly. This is another paper, this is published in Diabetology. They have included, see the sample size, 8,58,000 with the 28 patients with the coronary events. What was the message from this slide? These meta-analysis showed women perform very badly in terms of cardiovascular disease. So don't you think it's a very significant issue in females? Definitely we should address this issue. Of course, India, there are good papers are coming up in this regard. Coming to the other papers, this is again from Diabetes Care, sex difference in diabetes and risk of incident coronary disease, healthy, young and middle aged. What it shows, females' performance is not good. You can see the hazard ratio, it's very significant here than males. Now, let us explore what are the predisposing or what are the contributing factors for all these things. Number one, cardiometabolic profile is not good. Glycosylated hemoglobin is not under control in all the cases. Even ICMR data shows in both sexes, glycosylated hemoglobin is not under control. Low frequency of lipid lowering treatment. It is said that, it is documented that ladies are not taking all the prescribed medication, not taking proper follow-up, even though their awareness status is good, but they are not following it. Low incidence of aspirin usage, blood pressure control is not very good, And even in outpatient setting, even after coronary syndrome, they are not taking medication properly. And revascularization failure rate is also very high in case of females. My friends, let me move to another topic, heart failure. See the risk factor, five-fold higher risk for developing heart failure in females. And maybe a difference in many levels, but sex disparities needs little care. Coming to the hypertension, normal tendency females typically no BP. When the age reaches around 60 or 65, they are developing little hypertension. And what is written here is Western New York Health Studies strongest indicator for developing issues. And it was IFG is responsible and weight gain after 25 years. These are the predictors for developing hypertension in future. Of course, this is linked with our leptin. See, Dr. Srinath was discussing certain cytokines like pituin, you have neuropeptinos, all those things are important in terms of the hypertension issues. Now, coming to the other risk factor, that is stroke or cerebrovascular disease, these ladies with diabetes mellitus are high risk for developing stroke, and similar risk is in all stage in coronary disease also. Recent advances made it clear when compared to the male diabetes, the female diabetes had a very high risk for developing stroke. If you want to see the data published in Lancet, diabetes as a risk factor for stroke in women. See what is happening here? Very bad profile in females. If you see all these data published here, this showed the high risk for developing diseases that is stroke. Coming to peripheral vascular disease, 3.5-fold in males, but in females it is 8.6-fold. Don't you think it's very significant? Definitely, and they're not doing very well with the treatment also. These are the important statements we should know. The peripheral vascular disease is very badly affected in females, and eventually amputation level is also increased as age advances and in females. That is very important statement. Coming to the nephropathy, my friends, diabetic nephropathy is conflicting reports, inconclusive reports, but they are having high mortality, especially those who are going for chronic dialysis. And Gomez et al. They demonstrated vascular changes, renal damage in human, and very badly affected in this group of patients. Lastly, the women are more likely to develop non-albuminuric variant, but males are developing albuminuric diabetic kidney disease. There are changes. If you see the data, this is for type 2 diabetes mellitus only, not for type 1. So what is shown here, more risk is documented at least in 11 papers, and more risk is documented in 3 papers. But I have a feeling that these women, they are doing very badly, but there is no such difference also documented in 2 papers in type 2 diabetes mellitus. Whereas for type 1 diabetes mellitus, men or males are more risk for developing diabetic kidney disease than female. So there are conflicting reports, controversial report, inconsistent report, but whatever said and done, it is very clear that women, they are having very bad disease. Now coming to the other microvascular disease, that is neuropathy. Neuropathy patients are coming, or male patients are taking treatment or taking checkup. They are detecting neuropathy and they are going for interventions. In females, they are not doing it. See, that's the conclusion from this study for neuropathy. Retinopathy also, this is Salath paper, but they showed that there is a strong risk factor for women. If they are developing proliferative, there's a strong risk factor for developing proliferative diabetic retinopathy. Gastroparesis, the incidence is very high in females. Of course, males also have, but those who are obese women and very high levels of glycosylated hemoglobin, the gastroparesis is also very high. These are the comorbid issues which can contribute to the failure of treatment in type 2 diabetes mellitus in ladies. Now, this is the bird eye view. For the last 20 to 25 minutes, I was discussing all these issues. Nephropathy, you can see here the central line, what is shown here, nephropathy is very badly affected. Lower limb amputation, male and female, but females, definitely there are chances for diabetic foot problems. Coronary artery heart disease, most important cause of mortality. Stroke is also significantly increased in diabetic ladies. Mortality, of course, subsequently or obviously that will increase. Obesity, in this data, obesity is slightly more in males, but of course, females also have vascular disease. Those who need dialysis also, chunk of patients are from female sex. Now, comorbidities is more common in females. Limitations, if you can read here, limitations are more in females. Cognitive problems, depression, anxiety, pregnancy with complication, sexual dysfunction. Of course, you can get both sexes, but unfortunately, we are not bothered to look into that sexual dysfunction females. So, what is written here is around 50% of the females, diabetic patients, they are having sexual dysfunction. We are not really bothered sometimes. Now, coming to the next slide. Next slide is treatment differences. Let us see what's happening. So, cardiovascular lifestyle treatment for reducing cardiovascular events, no difference documented in few studies, but observation studies suggest that women with diabetes mellitus may require more frequent physical activity than male to reduce cardiovascular issues. Glycemic control, what is shown here, glycemic control is good, similar, but men and women with pre-diabetes had similar weight loss in diabetes prevention rate in US diabetes prevention program and other prevention studies also. Coming to certain medications or pharmacotherapeutic agents, you know metformin is one of the best, but tolerance is slightly less in case of females. And what is documented in the literature is, even though we have not seen this lactic acidosis, high rate of lactic acidosis documented in females. Glitazones is a good molecule, but glitazones is not good for elderly, obese patients, osteoporotic patients. All these patients, it has got a negative impact. So glitazone, we should be careful. Regarding sulfonylurea, in both sexes, it's okay. SGL2, it's very important. Cardiovascular outcome in females may different than males, because there are certain green signal to conclude the message like that. Incretin-based treatment, if the patient has got obesity, females has been shown to reduce the weight, more weight than females. Insulin, very interestingly, more events with hypoglycemia and severe hypoglycemia documented in females. These are the messages in terms of treatment. Other drugs like statin, one of the commonly prescribed molecule, very high incidence of myalgia and muscle disease or muscle enzyme elevations documented in this group of patients. And fenofibrate shows more reduction in CV endpoints in women and than males than in the field study. This study is a very congested study. I want to show only one statement here. Bariatric surgery is a strong diabetic risk reduction. Higher frequency of bariatric surgery in women due to differences in their thought process, but the complication rate is also slightly high. So, in short, there are differences in the management of type 2 diabetes mellitus in these sexes. What is shown here is very interesting. This is, I think, the India is taking part certain movements for reducing the cardiovascular issues. On the left side, what is shown here is 85% of the women agree that regular medical checkup is a must. And 50% of the surveyed women have not had themselves examined for diabetes. Ignorance is a very common issue among women. For 50% of the women believe that exercise and yoga are beneficial, still they are not doing it. And 35% of them admit to lack of exercise in their daily life. As I discussed earlier, they are not doing any exercise. So, my dear friends, ladies and gentlemen, what I want to tell you that gender difference is definitely prevailing in diabetes mellitus. And what I understood from the literature, females are outnumbering and they are having more risk for developing diabetes and diabetes related complication, both microvascular complication and macrovascular complications, very high levels in females. That's all from me. And I want to conclude that we should empower our ladies to get treatment, proper treatment, and proper monitoring, and you can prevent diabetes related complication. So I'm stopping here. Thank you very much for the kind attention of the topic. Thank you very much. Over to Singh sir and Manuel sir.
Thank you, Dr. Jabbar, for excellent presentation, almost covering up. I would say you have become more gender expert than of diabetes problems in females. Very rightly said that females needs more attention for diabetes aspect, as they are more easily inflicted with the diabetic complications, though initially they are protected, but at the end they do not fare better than man. Over to Dr. Manuel for his comments. Meantime, I request Dr. Sinha to prepare the result, and I request him to come over the dais and declare the result and also discuss the answer of these questions which he has asked. So over to Dr. Manuel for his comments and his experience on gender differences in diabetes.
Well, thank you very much for inviting me. It's an honor and also a pleasure to share with you this, that's about a couple of hours that this webinar is going on. This is a very important issue, and I have about 40 years of experience with diabetic persons. Nowadays, I'm working in another part of Barcelona, in Germán Trias Hospital, which is the referral center for about 1 million inhabitants. And the city which is close to Barcelona, in the metropolitan area, northern metropolitan area of Barcelona, it's called Badalona. This is a place where we have a, let's say, multi-ethnic population background, meaning that we have a lot of people from Morocco, from North Africa, from China, from Pakistan, from India, and also a quite important Gypsy community. I would like to acknowledge the whole presentation that Professor Jabbar made. It has been really fantastic, but I will emphasize the last part of his presentation, in which a certain message regarding how women have access to a medical treatment is of importance. From my experience in the last 10 years, when I'm working in this hospital in northern part of Barcelona, which, as I said, we are receiving a lot of different countries, people from different countries, in which the situation or the position of the woman in the society is different from the one of the men. I would certainly confirm that also in people in the communities which are living in my country for many years, this is something that we have to fight. And this is quite complicated to do when there is some, let's say, ethnical, religious, and also idiomatic barriers. So what we are doing now in my hospital is to try to have doctors from these communities that could really work in the very deep position of these societies in the neighborhoods. We have second generation of all these countries which have already acceded to careers. And I am very proud to say that people from these countries have also been doctors which I have teach in my university. And now we are trying to build Gypsy doctors, Indian doctors living in Barcelona, which could be able to go even closer that, let's say, people and doctors from Barcelona when we have to take care. This will be very helpful. So this is very important. The position, the social position of women makes differences even in a a country like Spain, where we have free access to public hospitals, and public hospitals are really of good quality. And the other questions regarding the biological basis of these differences have been really, really wonderfully reviewed by Professor Jabbar. So I'd like to congratulate his presentation, and I'm going to close my talk here. The quiz are very interesting. I might participate in the discussion when we will go question by question, but obviously all the questions have been really central in the message that this webinar has to give to the audience as conclusions. So thank you for the invitation, and I'm open. My microphone will be closed or open regarding if you want me to comment specific topics, but I would like to just say thank you so much, but also congratulations for the presentation and the initiative.
Thank you, Dr. Manuel. Thank you for your comments. And now I invite Dr. Srinath to take it over and disclose the results and also discuss the answer. So first he can discuss the answer of the questions and then disclose, or the way he thinks would be right. In fact, most of the answers have already been given by Dr. Jabbar. Almost every year.
Yes, sir, but I haven't received any answers till now, sir.
Oh, no. So they were waiting for the answers from Dr. Jabbar, and I guess anybody can answer it very easily now. But truly speaking, from my heart, that before the presentation of Dr. Jabbar, I would have also failed in answering these questions because we do not read so minutely about the gender and the.
Sir, in fact, I discussed with my colleagues. Okay, they were telling that I never knew that there's a difference between gender. Okay.
No, we knew that there had been differences, inter-heart study and enhanced data, but we didn't know that so much of minor details, which that required very good preparation. In fact, one good.
Maybe one of the issues that deserves some comment, it was in some of the questions, but also in the presentation of Dr. Jabbar. We all have been working with BMI for many, many, many years. And BMI seems to be a very non-precise way to measure the risk in one way, but also the fat excess. When we, as Dr. Jabbar presented, topographic images of the concentration of the abdominal fat, these I presume that's going to be more and more used, for example, by calculation of by mean of bioimpedance, which is the percentage of excess fat. And as a matter of fact, the overweight category, when we measure the fat content by using, for example, bioimpedance, almost disappears because most of the what we call overweight according to BMI goes through the obese category. So this empirical way to categorize according to numbers of cutoff of BMI doesn't fit very well with the risk. So measuring abdominal circumference or directly measuring quantitatively the excess fat by bioimpedance, or if you can go on and even have an image, then this is super. But BMI, as you know, it's not the same in Asia rather than in, for example, European continent. The cutoff values for different risk categories of, for example, cardiovascular disease, somehow equivocal. I would like to just open the discussion with this topic.
Yeah, Dr. Manuel, you're right. I think there had been observation that obesity is more common in women than man in any population, and that's correct for our population also. but the prevalence of diabetes is more in man than women for the age-matched cohort. So we have more men with diabetes than women for the same age, but obesity is more in females than male. And the parameter of obesity had been BMI. So BMI may not be a very good indicator, as you have already, you have also said, and Dr. Jabbar has presented, that it is the fat localization in the body is more important than the total amount of the fat in the body. Yeah. And subcutaneous fat is more in women than the visceral fat, which is metabolically more causing the problems of glucose intolerance. And the other issue that we had done some observational study and shown that the waist circumference in men and women should not be that much different. Most of the data has suggested, like ASEAN, it is 80 centimeter for women and 90 centimeter for men is normal, and more than that is associated with the metabolic problems. But we suggested that 85 centimeter in women and 90 centimeter in men, because the women, if we narrow it, we can perhaps judge the prevalence, why the prevalence is higher in men than women, and this difference may not be that remarkable. So we suggested that the waist circumference difference in men and women should not be that much, which was our one paper, and we used that ROC. Using that ROC and the metabolic parameters we showed published in IGAM long ago. But then I didn't see any publication related to this, that the waist circumference difference should be narrowed down in order to make the women also having more risk of developing diabetes than men. And perhaps that gap can be further narrowed down. That's my perception. It is open to more study and more observational data inputs to prove what we are thinking about, that the cutoff should be narrowed down for metabolic complications. Dr. Jabbar.
Yes, sir. I do accept, sir. I fully accept your comment. That's good. Over, sir.
So there is no question, no answer coming out from the QAs.
Sir, they have sent the answers. Right now I saw them.
Yeah, please.
Yeah. So can I discuss now, sir?
Yeah. You discuss the answer first and then disclose the winner.
So the first question was, type 2 DM is more frequently diagnosed at lower age and body mass index in men. The statement is true, and it's already been discussed by Professor Jabbar sir. And the second question, visceral adipose tissue to subcutaneous adipose tissue ratio independently predicts higher cardiometabolic risk in females. And that is also true. Whereas in males, the predictors are visceral adipose tissue and age. Third question is, menopause is associated with shift from gynoid to android visceral adiposity. And the answer is true. That statement is also true. And we all know that with menopause, there is loss of estrogen production. So there will be a preferential increase of abdominal fat. The fourth question, higher impact of brown adipose tissue contributes to higher diabetes risk in women. The statement is false. We know that the brown adipose tissue gives a protection against diabetes. And in studies, it has been found that women have much higher prevalence and activity of brown adipose tissue. And some studies have also shown that BAT transplantation has reversed obesity, increased adiponectin, and reduced insulin resistance, as well as liver steatosis. Fifth question is, new biomarkers shown to be related to type 2 DM onset in women are all except. The question it is specifically asked in women. The point is that in the option A, B, and C, that is hepatokine, futin A, copeptin, and proneurotensin, They are all the new biomarkers which are shown to be related to type 2 DM onset in women, whereas the gamma glutamyl transferase, the liver enzyme, it is shown to be related both to men and women. And the next question is, among the liver enzymes, the strongest association with incident type 2 DM is seen for, it is gamma glutamyl transferase. And we all know that the gamma glutamyl transferase is more closely related to fatty liver, oxidative stress, and thus it can lead to insulin resistance. Next question is, testosterone replacement therapy can improve insulin sensitivity and hyperglycemia in hypogonadal diabetic males. That statement is also true. We don't know whether the testosterone deficiency itself causes metabolic derangement or the testosterone levels are decreased because of aging, changes in body composition, or illness. But still, it has been found that if we replace testosterone in hypogonadal diabetic males, it improves their insulin sensitivity and hyperglycemia. And men often, more often develop impaired glucose tolerance, and women more often show impaired fasting glucose. Dr. Jabbar sir has detailed this in his lecture. So this is a false statement. We know that in females, it is the impaired glucose tolerance, and males, it is the impaired fasting glucose. And because the main reason for this is that in females, there is delayed gastric emptying, and so because of the delayed gastric emptying, there will be prolonged gut glucose absorption, and all these factors can contribute to higher glycemic levels during the oral test, and thus to higher prevalence of impaired glucose tolerance in females. And pregnant women carrying a male fetus have higher risk of developing GDM. And this is a new thing which I came across while preparing this quiz. And because the reason for this they have stated is that it might be related to the actions of Y chromosome on the placenta-derived hormones like placental lactogen and prolactin and other proteins as well, which are involved in the beta cell mass expansion. So what about pregnant female who is carrying a female fetus? And the GDM mothers with female fetus, they have lower beta cell capacity. So it can lead to higher risk of type 2 diabetes mellitus and early onset over time. And if the mother is carrying male fetus, the decrease in beta cell function which occurs during pregnancy, it happens only in pregnancy, and it will get resolved after delivery and restitutes to former capacity. Then the 10th question was, women appear more vulnerable to stress-related weight gain compared to males. It is also true. And we know that the ghrelin and the other orexigenic anxiolytic like neuropeptide Y increases with stress, contributing to the emotional eating, which appears to play a greater role in females. And not only that, women are also shown to have lower ability to suppress hunger. And the 11th question was, there is a positive association between BMI and heart failure risk among men, but a J-shaped association among women with type 2 DM. It is true. And regarding the heart failure, males tend to develop dilated cardiomyopathy with myocardial dilatation, whereas women tend to develop hypertrophic cardiomyopathy with diastolic heart failure and preserved ejection fraction. And the last question, diabetic men carrying angiotensin converting enzyme D allele have a higher risk for development of diabetic nephropathy. It is false. It is a females. Diabetic females who carry ACE-D allele have a higher risk of development of diabetic nephropathy. And some epidemiological cross-sectional data points to the higher risk of proteinuria and renal disease in women than men among the type 2 diabetic subjects. So these were the answers. And among the participants is Dr. Anna Montero. She scored 9 questions right out of 12, and she is a winner for today.
So congratulations to the winner, Dr. Anna. Any questions from the audience in the chat box? Or the host can send the questions to us and to the speaker. So if there is none, I think I give it to Dr. Manuel again for his closing remark.
Yeah. Sir, there is a question from Dr. Haris Muhammad. from Ambatena. His question is that studies have shown a higher incidence of poor drug compliance in women. Is this due to higher incidence of depression in them?
I think it's a
Dr. Jabbar?
Some multi-factor reason. It's a well documented that the compliance is less. Okay, they're not following your treatment. You are writing a number of drugs, they're not following it. There may be a contribution from depression also. See, in accessibility is also a problem. Suppose we have seen a lot of patients when we were in Bombay. At that time, the females are not coming to our hospital because of many reasons. So what I want to tell you that the statement is true, and there are multi-factor reasons for that. That's all from me. Thank you very much. Over to Sanjay or Singh sir.
Yeah, it's correct. Yeah, yes, correct. That women, for various reasons, could be a social, economical, and their knowledge about the disease could be a factor that drug compliance is a big issue in females. We have seen in our clinics many times female used to say that they had been taking it. They hardly say that they are taking medicines. So they had been taking when they become sick. Again, they come to clinic, and this has been quite common with females. The other important is that males, if they fall sick, even females are looking after them and asking them for the compliance. But when females are having disease, the males are not persuading them to take medicine in time, and because they have to look after themselves. So that could also be another factor, very important. Yes.
Thank you.
Any other question?
Dr. Manuel, how is it in Spain?
Yeah.
The same gender discrimination and also the ethnic issues in Spain regarding depression and adherence?
Well, I would say that there are no gender discrimination in the access to medical advice and treatments. And depending of the question of the multi-community we are having in certain parts in northern and southern Barcelona Greek area with these different multi-ethnic communities in which this can be of importance. In general, in the country, in Spain, there are no gender differences of the access to medical attention. What we are experiencing, because we are studying at the community level, is some questions that are pre-diabetic factors, like, for example, fatty liver disease. And the prevalence of fatty liver disease and in parallel to obesity is growing at a very, let's say, concerning speed. When we are performing, for example, different ways to measure with fatty liver score indexes in which triglycerides and abdominal circumference, and we complement with, for example, ultrasonography, the prevalence of this pre-diabetic condition is really higher than 50% of the population. If you add to that in comparison and a different way, what would happen, for example, in India and Pakistan, where I presume that the alcohol consumption is lower than in Europe, here we have the obesity problems, which lead us to a lot of not just fatty liver disease, but also muscle steatosis, pancreatic steatosis, epicardic steatosis, together with visceral steatosis. And this is something which is increasing with the age. And we don't know, we are studying that, if this is also different between genders. Obesity is one of the tracking conditions to non-alcoholic fatty liver disease. If you add alcohol consumption in Europe, this goes even up, meaning that the scenario we're facing is more obesity, but also more diabetes related to fatty liver disease. And well, this will be necessarily faced with therapeutic interventions at the community level, and which is very difficult because, you know, everywhere in the world, everything is celebrated eating with families, with friends. And in Europe and in Occidental countries, this is very much in addition with alcohol during the meals. So this is a problem. Particularly women, we believe that they are much more sensitive to all these social and overeating situation in Occidental countries. I don't know in India it's going to be the same, but I presume that it will be also the same.
So, yeah, you are right, Dr. Manuel. I think it's almost similar. We also see women having fatty liver, and most of the time they are investigated for some other region. Ultrasound is routinely done, and a grade 2 fatty liver. Most of the time, we are asked what is the significance of grade 2 fatty liver. In fact, this is NASH, and usually it is not addressed because there are many more problems associated, and they are more acute problems which are addressed, but the chronic problems are usually overlooked. I think that's the time we should also be sensitized to look at it, that they have a fatty liver and they should be investigated. The dietary management should be enforced. Yes. So over to Dr. Yeah.
Sir, 1 minute, sir. With your permission, sir, along with Dr. Anna, Dr. Debadityo Das from Kolkata has also scored 9 out of 12. So that means both of them are winners.
Yes.
So it was my mistake, sir. So,
okay. So they should be congratulated.
Yes, sir.
Devrat from Kolkata.
Kolkata.
Anna. Good.
Thanks.
So over to Dr. Sanjay Kalla.
Thank you, sir.
Is he online? Yeah.
Yes, sir.
Yeah.
Thank you, sir. We had an excellent quiz today. Thanks, Dr. Srinath. We had an excellent speaker. Thank you, Dr. Jabbar. You put in perspective all the differences. And I honestly didn't know that there were so many differences. It was an eye-opener for me. And our chairpersons, Dr. S.K. Singh, sir, and Dr. Manuel Puch, thank you very much for being part of us.
Thank you.
Dr. Manuel, especially on behalf of the entire country, India, on behalf of the Endocrine Society of India, we thank you for having spared time to be with us. We look forward to continued interactions with you, with Spain, with the endocrine, with the European Society of Endocrinology. Thank you.
Yeah.
And to all our viewers, thank you very much. And we hope to see you again next week. Like I said, we are a gender sensitive society. Today we've had all men. But if you see, last month we've been discussing transgender endocrinology. And if you see all our activities, you will find that our youth, which we call Yuva Crinology. Dr. Manuel, in Indian languages, Yuva means youth. So we have a very strong Yuva Crinology brigade. Srinath is part of that. This is equivalent to the EYES, EYES, that European Society has. And you will find that there is a good geo spread, a good ethnic spread, and of course, a good gender diversity in our organization. So thank you, and we look forward to meeting you again next week. Jai Hind.
Thank you.
Thank you.
Thank you, Dr. Manuel. It was a pleasure to be part of with you. Thank you.
My pleasure.
Thank you.